Hi, this is Brian Kim. I'm going to share with you case number 81 in the best way to do cataract surgery series. This patient has one of the worst floppy irises I've ever seen. I did his first eye and it was really difficult. The patient had such thin and diaphanous iris. And so this is his second eye. And I went in kind of proactively making sure I was going to put in all my iris hooks and handle this really challenging iris. And so again, just looking at him, it looks fairly benign. It doesn't seem like there's going to be anything unusual about his case. However, his iris is so wispy thin. And on top of that, he has not a great exposure. He's got a tight fissure and a small pupil. And again, this really thin iris. And so I'm making my incisions on each side first, and then I'm going to be making my iris hook incisions. I like to put in 5 hooks. I put 4, and then I like to put a sub-incisional hook, because when you go in and out with the incision in severe floppy irises, the iris wants to come out of your main incision as well. And once it comes out of your main incision, it just finds a home there. And because it gets so stretched out and it's so atrophic, it just kind of continues to get in the way. And so the best way to handle these cases is to avoid the problem, not have to manage the problem. And so we're going to be proactive, placing my corneal incisions, and now I'm placing a scleral incision subincisionally. I'm injecting some intracameral lidocaine. I usually like to put in the hooks before I put the viscoelastic in. And the reasoning is sometimes if you put too much viscoelastic, the iris gets bowed back and it's actually harder to reach the iris. And so that's the rationale here. And you'll see so far it's working okay. I got the subincisional hook in first, and now this one's going in. You can see it's not really a U-shaped hook, it's more like a J hook. And so we'll see how well that one holds. This is the third hook. But you can see here, because the chamber is not great, as I'm putting the hook in, it actually causes a transillumination defect, which just kind of blew my mind that I'm placing this hook in and now the patient has a transillumination defect. And so I'm going to go ahead and fill the anterior chamber a little bit, try to at least make the iris more flat and not bowing upward in a convex configuration. And so now that I've inflated the eye a little bit, I'm repositioning that hook and it looks a little bit better. But again, when I saw that transillumination defect just barely touching the iris, it just kind of really reiterates how thin this patient's iris is. So again, you like to use the stopper to help control and twirl the hook. And so that's what I do. I place it in, make sure the stopper's further back. This allows you to reach the actual hook to the pupil edge, twirling the stopper so that the hook is facing downward if necessary, and then grasping it at the tip and then pulling it up. So as I was saying before, that second hook, because it's not really a U-shaped hook at the end, it's like a J-shaped, it really didn't hold that edge very well, so I had to go back again. And so these hooks are reusable, and that's good and bad, but again, because it's reusable, you saw that that one hook was a little bit deformed, didn't have enough of a hook to it. And so we'll see how that goes as the case progresses. Again, I'm trying not to pull too much on the iris because, this iris is so thin, if I pull too much, you might have this really super flaccid and dilated pupil at the end. So I injected some dispersive viscoelastic, and this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter very carefully. Again, I have my iris hook already in place, so it's a little bit of a challenge. I could have alternatively left that hook out, made my incision, and go in later, but I already did it the way I did it, and so that's fine. I injected some more dispersive viscoelastic to fill the chamber, and the chamber is a little bit on the shallow side. Again, shallow chamber, very, very thin, diaphanous, severe IFIS. Again, learning from that first case. Tight fissure, not a lot of room for my iris hooks here. And so I'm going around circumferentially. I did place my corneal marker to mark the cornea, so I'm able to hopefully get a rhexis that's appropriately sized and centered here. Took me a while to find the edge there, and once I do, I go ahead and finish off here the rhexis. I'm going to go ahead with the capsulorhexis hydrodissection technique, but before I do that, I'm putting a little bit more attention on the subincisional iris, because as you do the hydrodissection, it does cause a bolus of viscoelastic to usually come out as you're pushing the VSS, and that can cause iris prolapse. And so I tighten the iris hooks a little bit. This is a capsulorhexis hydrodissection technique. I place the cannula out underneath the rhexis edge, pointing the tip down. I'm being very ginger with the fluid wave here, just because I know about the potential for iris prolapse. I decompress on the left side, point the tip down on the right, and very gently and slowly start to turn the lens. So again, with floppy iris situations, you don't want to do a vigorous hydrodissection. You want to be a very slow and methodical hydrodissection. I irrigate the surface of the cornea. Go in with the chopper, lifting the incision with irrigation off to minimize Descemet's trauma. And then I start to remove the surface epinuclear material. But then I realized that that same hook, that second hook I put in, is coming off again. And so what I should have done was just switch out hooks to something else, because instead of it being a U-shaped hook, it's a J-shaped hook, and it's just not holding it well enough here. So here I'm just trying to make sure I don't grab the capsule. And so for some reason, as I'm doing this, it keeps catching the capsule. So I had to reorient it, make sure it doesn't grab the capsule, and then I'm retracting the iris here. So it took a little moment. Again, probably a better idea if I just switched the iris hook completely out, because it might be a problem again later. So I've removed all the epinuclear material, placed the chopper underneath the rhexis edge contra-incisionally, pointing the phaco tip vertically subincisionally. Crushing the lens in half, that's the double chop, placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip, crushing it against the phaco tip. That is the cross chop. Using some vacuum to lift that first quadrant up, sandwiching the lens with the chopper and phaco tip, and then emulsifying that first quadrant. Whenever the iris is very weak, I'm also suspicious of weak zonules. Place the chopper around the second quadrant, pulling it centrally toward the phaco tip, crushing it and dividing it, and then doing some successive mechanical fracturing forces, sandwiching and crushing the lens pieces, and then emulsifying the lens pieces. You can see that the bag is a little bit wobbly as I'm doing the case here. I prolapse that second piece up from the second quadrant and then emulsify it. I'm rotating the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, which is deep, crushing and bisecting that second heminucleus, lifting up the third quadrant with a little bit of vacuum, crushing it between the chopper and the phaco tip, making it smaller and smaller, and then emulsifying the lens pieces. Placing the chopper around the fourth quadrant, pulling it centrally toward the phaco tip, crushing it, bisecting that lens piece, crushing it again with mechanical forces, and then emulsifying the lens piece. Getting the chopper around this last piece, pulling it up out of the bag, crushing it, and then emulsifying it. So now the endonucleus has been removed. I'm going to carefully remove the epinucleus, grabbing the anterior portion, and it's starting to prolapse out quite nicely. I'm making sure the chopper is deep in the bag, making sure that the bag doesn't come with as I'm removing the epinucleus. So I take the chopper out, push BSS in, take the phaco tip out, and very carefully going in with the INA handpiece. Start subincisionally, sweeping side to side, making sure I'm peeling the cortex and not the capsule, going around circumferentially, going back subincisionally here, trying to grasp the, again, anterior edge of the cortex with foot pedal modulation, and then going around circumferentially, peeling it. Again, using foot pedal modulation, very carefully and slowly removing the cortical material. You saw that it puckered the posterior capsule at that very end, and that's the beauty of the polymer tip. I switched to polish mode, polishing underneath the rhexis edge of any lens epithelial cells. Whenever you think you have weak zonules, it's good to polish underneath the rhexis edge to minimize capsule phimosis in the future. I'm polishing the posterior capsule. As I'm doing this, you can see it's creating quite a bit of stria as I do this. And this is a telltale sign that the zonules are a little bit on the weak side. So I'm pushing cohesive viscoelastic to fill the bag now. I did not bother to pulse the subincisional fornix in this situation. Just polishing on the left side with the capsule sweep. And then now on the right side, you can see how thin the iris is. You can see the iris hook at about 1 to 2 o'clock position has already disengaged from the iris edge. And so you can just see it's just not a really good iris. And again, I didn't want to put so much tension on it, and which can cause iris tears in this very thin and diaphanous iris. I inject a single piece of acrylic lens into the capsular bag and disengaging the haptics from the optic with the capsule sweep here. So now I'm disengaging the iris hooks from the pupil edge using a two-handed technique, grasping the hook first and then pulling the stopper back. Grasping the hook, pulling the stopper back, making sure it twirls off the pupil edge, and then you pull it out. So that's the technique. Grasp the iris hook proximal to the stopper, pull the stopper up, disengage the hook from the pupil edge, twirl it, and then pull it out. So I go in with the INA handpiece, activate irrigation. There's a little nugget of Cortex that was subincisional just to the left of me. I go under the optic, removing the viscoelastic from within the bag, reposit the lens back, switch to polish mode, polishing under the rhexis edge and twirling the haptics so they're more in the horizontal meridian. As you can see, I did not put a lot of traction on the pupil edge with the iris hooks. I didn't do a really aggressive retraction with the hooks here. If I did, I can assure you it would have caused a lot more iris damage. Again, I know this because that first case was just really a challenge. So I switched to visco mode, removing all the viscoelastic from the anterior chamber here. You can see the transillumination defects already. You can see the pupil is really very dilated. So I'm carefully pushing BSS to make sure the angle is free of any viscoelastic. And when I come out with the INA handpiece, I'm going to actually stop the irrigation before I come out so it doesn't encourage the iris to come out of the main incision. I decompress the eye, come out, and then I start to hydrate my incisions. And thankfully, throughout this case, I did not have any iris prolapse. This is a severe case of IFIS, really floppy iris, really thin and diaphanous iris. Despite having hooks in, some of them came off, and I had to, again, very carefully disassemble the lens. And that's the beauty of this technique, is I don't have to use high vacuum. I'm using mechanical fraction forces very systematically and methodically and very in a controlled manner, disassemble this lens, not worrying about iris being eaten with my maneuvers, since I'm minimizing high vacuum and only utilizing the high vacuum in the central safe zone after the lens has been disassembled. So I hope this was helpful to you, and I thank you for your attention.